The following podcast is part of a certified educational activity titled Streamlining Multidirectional Care in HCC, Applying Groundbreaking Evidence on Systemic Treatment Approaches Across the Disease Spectrum. Access the entire activity and complete the post-test at peerview.com/FRD860. Downloadable slides and practice aids are also available.
Good evening, everybody in the room and those participating virtually. Welcome to our educational session on hepatocellular carcinoma. I think this is a very important meeting because there are basically two issues to be mentioned in HCC. It's an important tumor, it's a very deadly tumor, and unfortunately a late diagnosed tumor. So there's lots to be shared with respect to that tumor. And in addition, we have news. There are new therapeutic options, and we would like to share that information. I feel privileged to be joined tonight by Anthony El-Khoueiry from Los Angeles and by Katie Kelly from San Francisco, both esteemed experts in GI oncology with a focus on hepatocellular carcinoma, and good people, by the way. We have certain goals. We would like to, of course, focus on the recent improvements, particularly with respect to immunotherapy in the treatment of HCC. We'd like to highlight that this is a very personalized treatment. These patients are more complex than average tumor patient. They suffer from liver disease, and liver disease has in some patients a much greater impact than the tumor burden itself. And other aspects are to be integrated because this is a multidisciplinary team approach where the surgeon, the interventional radiologist, the oncologist, the hepatologist all play a role and give advice, and that should be done on a regular scale. And it's actually not happening in reality, and that's something we will address as well. In the end, those multidisciplinary team approaches are beneficial for our patients. I'd like to get started, excuse me, with the first session, and that is what are the unmet medical needs, what's the background of that disease. It's a relevant disease. We have learned when we went to medical school that this is a disease of developing countries, sub-Saharan Africa and in Asia, but it's actually getting more and more even in the Western world. And the problem is that almost 1 million are diagnosed newly per year, and most of these people actually will die. There is an increase in the younger population, and we have a dramatic burden coming from metabolic dysfunction-associated liver disease, what in the old days was called fatty liver-driven HCC. And in some parts of the world, for example in Mexico, this MASH-derived HCC is the killer number 1 in tumor-related death in some areas. So that's important, and we see an increase, and when we do a forecast on how that's going to develop into 2040, then we expect an increase of about 50%. So an important tumor, a deadly tumor, but the good thing is we do have more and more options. There were 2 major milestones in the last 20 years. In 2007-8, it was sorafenib entering the stage, defining HCC as a treatable disease. It was not just the TKI that was effective, but it was a principal new aspect. It's a systemically treatable disease. And in 2020, it was the combination of Atezo and Beva, which proved and was approved for HCC to be superior over sorafenib. And then there are other steps in between, which we gonna highlight. So we have to do a check what is in the end happening in reality, and it's sad to realize that actually only minorities getting treated according to guidelines in these days in 2026 using immunotherapy. It's still sticking, many treaters are still sticking to TKI therapy, and only a fraction of those getting treated in first line make it into second line. So that's definitely something where we need to get improved. There's tomorrow a poster by Richard Finn on quality assessment, and that confirms actually that physicians in charge to treat hepatocellular carcinoma feel insecure, do not adhere to guidelines, don't scope, they not pay attention to cirrhosis and the necessity to control for varices. So there is a certain gap between what is recommended in guidelines and what is happening in real world. And this is why we have those educational activities as of tonight. That brings in, of course, the role of the patient. And I was mentioning already that we are supported also by Blue Faery, Adrienne Wilson Liver Cancer Association. And this is very important because they provide information for the patient from patients. They inform about clinical trials and give the latest news. So that's a worthwhile effort to visit their webpage in order to appreciate the role of the patient. So let's get started with frontline therapeutic options as we have them today. And as I said, we are fortunate in that a lot has been developed during the last 20 years, and we do treat patients, and that is in contrast to the past, where we were basically only using IR, interventional radiology, or surgery. One of the issues in hepatocellular carcinoma is that we are not performing as good as we could. HCC is typically developing on the background of chronic liver disease. So the patient at risk, the patient group at risk is rather well defined. That should make it easy to get them early by using surveillance programs, but the opposite is true. As you can see on the left-hand side here, we do have to appreciate that in the Western world, the majority of the patients are diagnosed at advanced stage disease. This does not necessarily have to be the case, and that is a lesson we are learning from the colleagues in Japan, because they are able to diagnose a majority of their patients in a treatable situation where curation is an option. And of course, stage-driven diagnosis making is happily impacting the outcome. The 1-year survival is strongly depending on that. And we would not have to talk about therapy at all. We just would need to have an earlier diagnosis, such as in Japan, in order to apply curative intent, for example, surgery or ablation. So that's definitely something we need to get better. But then, as we are diagnosing our patients mostly in advanced stage disease, it's wonderful that we have options as of today. Most of our colleagues are using the BCLC staging system. It stages the patient according to tumor burden and adds the therapeutic options to it. And in advanced stage disease, and to some extent also in intermediate stage disease, we do have systemic options, and we will capture those options as they have developed. There are basically now 3 combinations available which we can be used. And what used to be the old standard sorafenib TKI is now rather an exception or happening in second line. Let's add some flavor to the situation and start. That was a patient of mine, alcoholic liver cirrhosis, developed an HCC that was quite undifferentiated, high alpha-fetoprotein. And as it was in the beginning accompanied by portal vein thrombus, it was clearly advanced stage disease. And I'd like you to keep that case in mind, and we will talk about the first-line options we have in that situation in due course. To get started with the first question, in 2026, you should ask yourself, and you should pose in the multidisciplinary team context, is this a patient for immunotherapy? Because this is offering the most benefit, and that's what we should get started with. Also, because those patients, because of liver disease, have a tendency over time to become unfit for therapy, and you should not miss that opportunity to offer what is most effective. And that would be, of course, one of these combinations, atezolizumab plus bevacizumab, durvalumab plus tremelimumab, or as of last year, nivolumab and ipilimumab. Those are the three combinations which in phase 3 trials have demonstrated superiority over TKI treatment, mostly sorafenib, but for ipi/nivo also for lenvatinib. And only if these options do not apply, for what reason soever, you have to consider whether you go for a single agent, durvalumab or tislelizumab have approval here, or because that is a rare situation that you would not allow combinational IO, but go for single agent. That is rarely the case in a clinical situation. The other option is then, of course, the use of TKIs. In some countries of the world, unfortunately, only TKIs are available. HCC is a theoretically well-treatable tumor, but it depends on approval status and availability and costs, of course. So let's have a look what was the approval basis for those pivotal trials. And as I said, in 2020, IMbrave150 set the starting point, and that was actually something very impressive. I'd like to remind you that in the old sorafenib days, in the SHARP trial, we had an objective response of 2%, almost nothing. So there was not a lot to observe. Here in the IMbrave150 trial, there was a response rate of 30% and impressive superiority over sorafenib. And what is also kind of unique for that combination is the very early separation of the Kaplan-Meier curve. So there's an early impact, maybe related to bevacizumab treatment, but nevertheless it results in a very nice separation of the curves, which is maintained. And some of these patients by IO treatment have a long-term perspective. Himalaya, it was not resulting in the same number, 16 months median overall survival versus 19 months here. But we have to appreciate that all these different trials have their different inclusion criteria, their peculiarities, and it's not really possible to compare the absolute numbers. However, Himalaya is little less toxic. This is one of the advantages. Maybe the absolute numbers, 20% objective response, maybe a little bit lower median overall survival. That all has to be taken into consideration. But it again shows landmark analysis for the long-term run, a very nice separation and a gain of about 10% even after 5 years. The efficacy is accompanied, and this is very fortunate for those frail liver patients, by a toxicity profile which is favorable for the IO combos. If you focus on the IMbrave150 trial, diarrhea and hand-foot skin reaction, that is something quite meaningful for the patient, whereas for atezo and beva, hypertension, proteinuria, well, that's something you measure, and it's not really impacting quality of life, and quality of life is in fact much longer maintained. Similar situation for Himalaya. Discontinuation rate was lower for this combination, so this is because it's applying tremelimumab, the CTLA-4 agent, only once, and that is sparing some toxicity. And in addition, in the Himalaya protocol, there were no relevant bleedings observed. The tremelimumab re-challenge, that's an addition of the Himalaya trial, also resulted in efficacy. And that gives us the opportunity to share, to look across those different options as we have them by comparing numbers. But again, let me focus that that is complex, as those criteria for inclusion and the patient profiles were different over the trials. But you can compare 30% objective response to 20% in Himalaya, duration of response 18 months, 22 months, and the absolute numbers for overall survival I've just shared. And then we may add the newest kid on the block, Nivo and IPI, CTLA-4 and PD-1 inhibition. And in contrast to Himalaya, where CTLA-4 inhibition by Tremi was only done once, here we had ipilimumab given 4 times. So more toxicity, certainly a little bit more toxic, this combination. But the numbers are actually quite impressive. 23.7 months of overall survival. Recall in SHARP, we started with a little over 10 months, and now we are reaching 2 years. Overall response rate, 36%, quite high, and a very long duration of response. I will tomorrow present the 4-year update, and that supports the previous observations. So let's dive a bit deeper into CheckMate 9DW, the Nivo and IPI combo, running against sorafenib or lenvatinib, which was by investigators' choice. And in the end, investigators choose to go mostly for lenvatinib, 85%. It was already at presentation in 2024 at ASCO, quite mature clinical trial comprising a period of follow-up of about 3 years. Tomorrow's presentation will cover 52 months. It was going primarily for overall survival and several secondary endpoints. Had an interesting shape of the curve where there was advantage of the TKI in the beginning and then a crossing of the curves. This advantage is actually the result of lenvatinib treatment. If you concentrate on sorafenib treatments, then you don't see that crossing of the curves. But the main advantage develops at a later stage. Complete response of 36 months, 36%, highest rate ever, and a very nice overall survival of 23.7 months. So quite effective, and that is supported also by the objective response data. Numerically, interesting to see that's actually quite similar. A bit more than 70% show a response either for ipi-nivo, for sorafenib or lenvatinib. But as it's obvious from this waterfall plot, the depth of response is much more pronounced for the IO combo. It's actually, if you, for example, take the numbers for more than 50% reduction in size, then it's 37 for ipi-nivo and only 8% for lenvatinib or sorafenib. And this is not just a number, something to measure. It has an impact on overall survival. And you can, if you use best overall response rate at 2 years, and then align those patients showing an objective response with OS, then you see that you are, after 4 years, in the range of 70%. That's really having a major impact. And what I also find impressive is if you take those patients who has best response, never showed a response, always showed a progressive disease. Even in those patients with progressive disease, median overall survival is 16 months versus 13.5 months. So you seem to get a benefit even if you don't respond. So there is some slower progression, presumably. An interesting question, and before Anthony and Katie fall asleep, I get them involved, is whether etiology plays a role. Apparently, all these different etiologies here, HPV, HCV, or uninfected, which typically is considered to be MASH, are showing response. Do you pay attention to etiology when you make a decision with respect to therapy?
I don't. I think these data and also the earlier Himalaya data, and also if one delves really deep into even the Atezo-Bev data, we do see that the primary oncologic endpoints of response rate and PFS seem to track regardless of whether it's Hep B or Hep C or non-viral MASLD. There was an initial meta-analysis, as you well know, looking at Atezo-Bev, nivolumab, and
very small meta-analysis.
Yeah, small meta-analysis, but they were really looking just at survival, and the survival did show a benefit towards the viral etiologies, but that really was all post-progression events. It doesn't work when one looks at the oncologic outcomes. Those seem to track very similarly according to by all etiologies. Anthony, do you agree?
I 100% agree. Yeah. I mean, this has been consistent even in the early phase trials with single agent Nivo, single agent Pembro, response rate consistent across etiologies, continues with the combinations. And I think the meta-analysis was overall survival. I mean, it's fraught with a lot of limitations, that analysis. So I think at this point, we treat them all equally.
Exactly. That was an interesting theoretical paper by the Heichenwälder group in 2020, pointing out to the idea that IO is not working in fatty liver. But as we have more information, it's very clear that those patients uninfected do show a response. And just an example, if you take Himalaya and look at HCV, no activity in this subgroup. And then a similar protocol, combination of PD-1 and CTLA-4, and here the best response. So that doesn't make sense at all. So it tells you subgroup analysis is prone to bias, and the prognostically relevant factors are not balanced. So etiology should not be a reason to base a decision for therapy upon. As I was already mentioning, CheckMate 90W shows a little more toxicity. Actually, if you go for the overall numbers, it's not impressive, but there is a little bit more with respect to serious adverse events, 28 versus 14, and treatment-related adverse events leading to discontinuation, 18 versus 10. So there is, and that's mostly CTLA-4-driven, slightly increased toxicity, something which we are actually relatively familiar with because this combination has been around for more than 10 years for melanoma treatment and so on. But pay attention, and it plays a role. This is also resulting in a slightly higher death rate, 12 fatalities versus 3. And 9 of these fatalities were actually liver-driven. We have to appreciate that in 19% of this population in CheckMate 90W, there was immune-mediated hepatitis, and most of them required high-dose steroid treatment. What is, however, interesting to see is if you go for patients with the baseline liver function assessment and separate those with good liver function, ALB grade 1, from those with poor liver function or worse liver function, ALB grade 2 and 3, what you see is the exact same hazard ratio. So you see there is efficacy, and in relative terms, it's comparable. But of course, this is prediction of therapy. It's not predicting therapeutic outcome, but it's prognostically relevant. Prognosis for good liver function is much better because the confounding impact of liver disease is here not playing the major role. And then you have 35 versus 16.9. So liver function upfront is not interfering with therapeutic success, but prognosis is impacted. And actually, liver function is better maintained by IO therapy over time, particularly since those impact on the liver, such as immune-mediated hepatitis, that's something which happens early on, starts at 6 months, and 6 weeks, excuse me, and is resolving at about 10 weeks. So it's something you can handle. I've mentioned now 3 options of combination therapy. They are approved in the EMA space and in the FDA space. There are other options, single agents, tislelizumab and also durvalumab. I'd like to mention that other combinations are also available. That's a combination camrelizumab and revuseramib, apatinib, IO and TKI, which is commonly used in China, not yet approved, but probably coming. So that's one of the other options, apatinib. There are others. And there are interesting trials going on. I'd like to highlight the Gemini platform investigating new agents. These are bispecific antibodies, PD-1 plus TIGIT or PD-1 plus CTLA-4. There is a BioNTech antibody, PD-1 and VEGF. That's very interesting. These biospecifics are interesting with respect to maybe better efficacy and lower toxicity, but we will see. Another issue is subcutaneous availability. We now have Nivo and Atezo for various indications, including HCC, available. Are you using subcutaneous applications?
I think, to me, it seems like the role would be especially important in low resource settings where patients may not have access to an infusion center, but may have access to an injectable.
Okay, let's get back to our patient. As I've mentioned, advanced stage disease, high AFP, undifferentiated tumor. You can see that the left lobe is basically gone. There's almost only tumor. So what do we recommend here?
And this is a pretty fit patient, Child-Pugh A. That's always the first thing we ask. Liver function, I think you already told us that. And portal vein tumor thrombus. I mean, I think any of the first-line regimens you just presented so nicely, the Tezobev, Nivo-Ipi, or Durva-Tremi stride regimen would be reasonable. If the patient hasn't had an endoscopy, I would favor, and if they can't get one in a timely fashion, I would favor one of the CTLA-4 combinations and either stride or Nivo-Ipi.
Patient had no varices. If there would be pronounced varices, would that impact your decision?
Definitely, we would avoid a BEV regimen.
Don't forget to scope. I think all those patients need to be scoped. So we enrolled this patient actually in the CheckMate 90W trial. And patient was doing fine, showed a response. I'll give you details on that. Developed hypothyroidism. Is that a problem?
No, I mean, again, this is an easily manageable immune-mediated.
Easier to replace by the thyroid, yeah.
My favorite.
I mean, what is important is take it as a signal. This patient has a problem with the endocrine system that could impact also the adrenal function, and I have seen a couple of patients extremely fatigued, and it typically takes a while until you get that diagnosis. So it might not be just the thyroid, but to replace thyroid hormone by T3, increasing dose, get the TSH in a regular range, that's actually very easy. Just consider. So what happened? You can see here that is a nice regression. And what was interesting in this particular case is that the treatment had to be discontinued per protocol after 2 years. So we took him off therapy, and that's the alpha-fetoprotein. It was rising initially, and then during Ipi-Nivo treatment, it normalized. And fortunate for the patient, over a period of 3 years, although it was by RECIST only partial response, the AFP is normal. So he is benefiting for the long-term run. So, Katie, it's your turn.
Thanks so much, Peter. And yes.
Thank you. I was hoping for standing ovation for this. Okay.
So Peter set the lay of the land so nicely with a lot of data, and I'm delving into a space that has much less data, a little bit behind in the game so far, relating to subsequent therapy or sequencing treatment after the first line for advanced HCC. So here's a reference case. This is potentially a similar case to the one Peter just presented, 63-year-old man with BCLC stage C or advanced stage HCC, but preserved liver function, Child-Pugh A, who also has known metastatic disease. So this is not liver limited, but frankly, stage 4 metastatic disease. And so let's say he receives one of Peter's first-line regimen options, but then progresses. So how do we sequence subsequent therapies? That's the next topic here. So this graph shows the current NCCN guideline options, and the take-home message is that there are multiple because we really don't have level 1 evidence to tell us exactly what to do after immunotherapy so far. And so you can see, again, these are the current options. They include some legacy options after sorafenib, which I'll briefly cover, cabozantinib and regorafenib. But also here in the middle, this sort of large list of options that are considered other recommended regimens. And they very clearly write out that it is rational in the absence of prospective data at this moment in time to consider regimens that are used in the first line that the patient has not already received, provided they have eligibility or no contraindications. So this is, again, the take-home message currently from NCCN guidelines in the US, are that it is reasonable to consider an alternate first-line regimen if the patient has not already received that class. And then there are, in rare circumstances, specific biomarker-based guidelines that actually, to be honest, have very few cases associated with them in HCC. There have not yet been, to my knowledge, cases of NTRK or RET in HCC. So these are tumor agnostic, though, so included for that reason. So just by way of a little bit of history, I think we all remember the tyrosine kinase inhibitors and anti-VEGF agents that have activity after sorafenib, given the long history of sorafenib as our only treatment line in the first line setting. And so we have the RESOURCE trial of regorafenib, the Celestial trial of cabozantinib, and the REACH2 trial of ramucirumab in patients with AFP greater than or equal to 400 nanograms per milliliter. All of these studies showed a survival improvement over placebo in the second line after sorafenib. However, we do not have such data after immune checkpoint inhibitors to date. And so this is a nice table that Anthony and Arndt Vogel and others compiled for a recent review article in JHUP Reports, which I'll direct you to. It's great. That shows some of the prospective data to date. And again, I'll alert you that this is limited and largely in the phase 1b or 2 setting. So these are not randomized trials for the most part, and they are small with heterogeneous prior first-line therapy. But we can see here the drugs that are studied in the post-immunotherapy, and again, a variety of different first-line regimens. The drugs that are studied in the second-line setting across these studies include cabozantinib, the combination of rego plus pembro, which Anthony led, and I'll show you in a moment, lenvatinib, that is, regorafenib, and then CTLA-4 PD-1 inhibitor combination bot-bal. And we can see again that this is single-arm data without comparator arms. But when we look at signals of efficacy, we can see that for the TKIs, we have a pretty low partial response rate in the single digit for the most part. When we get to the CTLA-4 containing regimen, we get an intriguing signal of activity with a 17%. We'll come back to that signal in a moment. But pretty low PFS rates, and again, not much we can draw from this table in the phase 1b/2 setting. So here's the largest study to date, the phase 2 study led by Anthony of the combination of pembrolizumab plus regorafenib in advanced HCC in patients after immune checkpoint inhibitor first-line therapy. Patients were treated in a single-arm fashion with oral regorafenib plus pembrolizumab. As you can see here, all of these patients were fit for trials, Child-Pugh A, and had appropriate disease for systemic therapy, BCLC B or C. And they were divided into 2 cohorts. Cohort 1 had prior atezo-bev. Cohort 2 had any prior other immune checkpoint inhibitor regimen. And this is a busy slide, but we can see here the take-home points on the far right that overall patients didn't stay on treatment for very long. Medium duration of treatment was in the single digit in both cohorts. The response rate was 5.9% for the prior atezo-bev group, 11.1% for the other checkpoint inhibitor group that perhaps hadn't received an anti-angiogenic, presumably, and had maybe a little more responsiveness. I think that, again, the take-home message is that while cohort 2, the regimen, the patients who had not received prior BEV but instead received other checkpoint inhibitors had a little bit longer PFS here on the left and OS on the right. Overall, these numbers are not dramatic benefit, and we can't draw too many conclusions in terms of adopting this as a next line of therapy standard. What other data do we have? So here is an interesting, rather large retrospective multi-center registry study that looked at real-world treatment outcomes in patients who received second-line therapies or best supportive care, BST, and divided them according to color into patients who received an immune checkpoint inhibitor in the second line after a first-line IO regimen. In pink, we see the TKIs in the second line, and in blue, we see the best supportive care. Obviously, this is retrospective data, and so there's huge prognostic imbalance on the decision to go with best supportive care. So again, this is not prospective data. But in the green, we see that patients who received an IO in the second line after first line IO did trend towards better outcomes. So again, an intriguing signal, worthy of further follow-up. Here's another really quite small study. Again, my disclaimer for this whole section is we don't have a lot of data here, so I'm showing you what we have to work with. And this is another small study looking at patients after prior atezo-bev who went on to receive nivo-ipi. And this is, again, very small with only 10 patients in this group. But the key take-home point is that some of these 10 patients, so 3 specifically, 30%, did have objective responses after on nivo-ipi after atezo-bev, with a fourth patient also achieving stable disease. So again, small numbers, but showing the potential for responses in this setting with adding a CTLA-4 inhibitor in the second line. And then here's another study from the group at Hopkins, looking at similarly patients who received nivo-ipi after any prior checkpoint inhibitor-based first-line regimen, including about half of the patients had received atezo-bev, and the other half had received other combinations. And we can see, again, the take-home message is not that we know for sure that this is the right thing to do, but that some of these patients achieved responses when you give them nivo-ipi after something else in the first line. And in this case, it was 22% achieved confirmed responses. So again, signal-finding data, but it's what we have to work with right now. So here is a trial that is ongoing that will help give us some prospective randomized data to help inform the information we're getting from these small phase 1 and 2 studies and from the retrospective cohorts. It's called IMbrave 251, and it really investigates the question of, is there benefit to continuing the checkpoint inhibitor after progression on the checkpoint inhibitor containing first-line regimen of atezo-bev. So in this study, patients who progress on first-line atezo-bev, so that's required for eligibility, get randomized 1-to-1 to either atezo plus either lenvatinib or sorafenib, so physician's choice of TKI, versus TKI alone, so either lenvatinib or sorafenib. And patients are then followed for for oncologic outcomes, including overall survival as the primary endpoint, and secondary efficacy endpoints, including the usual suspects, PFS, objective response rate, duration of response, et cetera, along with safety. And so this study has completed accrual. It's no longer recruiting, but we're expecting data, I hope, in the next year. I'm not sure when it will report out, but it will give us some really interesting, important benchmarks, even if it's a negative study. One, it'll tell us how TKIs perform in a prospective randomized second-line setting after atezo-bev. We don't know that. This will give us a benchmark just for lenvatinib or sorafenib alone. And then it will also give us a hint at whether continuing atezo with a TKI after atezo-bev is beneficial, as was suggested by that retrospective registry data, which is fraught with prognostic imbalance and selection bias. So again, an important study no matter what the results, and we can expect it in the next year. So putting all of this together, this is again a slide from Anthony's nice paper with Arndt Vogel et al., taking the current emerging data, which again, can't have too many disclaimers on the limited nature of this data. What do we do with the current data in our patients who we are seeing in clinic today before we have IMbrave 251 and other data to really inform it as what to do? So this gives us some suggestions based on the current limited evidence. So in a patient who received a checkpoint inhibitor with anti-VEGF, such as atezo-bev, based on those retrospective studies and registry data, and this is compatible with what NCCN would suggest, reasonable to consider adding a CTLA-4 checkpoint inhibitor combination. And so nivo-ipi or per NCCN, one could also consider the STRIDE regimen here. as a second-line option if someone received atezo-bev first line. And TKIs are also very reasonable in the second-line setting if patients haven't yet received one. And then downstream, we have really the selection, the armamentarium of TKIs, as we are well familiar with. Like on the right-hand side, we see what about in the case of receiving a CTLA-4-based regimen in the first line. In that case, we don't have data to do another CTLA-4 inhibitor-based regimen in the second line, so this would be a situation where TKIs are recommended in the second line if the patient receives CTLA-4 first. Lastly, this is just an important summary slide of where things stand today in terms of availability of drugs with and regimens in the first line setting in this top row and the second line setting in this bottom row. Pink are regimens that are both approved by the EMA and the FDA. Purple boxes are those approved by just the FDA in the United States. And we have a regimen here, camrelizumab plus rivocerimab, as Dr. Gale alluded to, which is approved in China based on the CARES 310 trial data. So these are all first-line regimens with level 1 evidence in different contexts. And then second line, again, right now, we don't know what to use yet. Next, the dotted lines are telling us that we don't have level 1 evidence yet what to use in these second-line setting, but these are the options on the table. So take-home messages, again, just to reiterate, in the first-line setting who received a combination immune checkpoint inhibitor, second-line option would be a TKI, or if they haven't received a CTLA-4 regimen, I think I and NCCN and we collectively think it's reasonable to consider a regimen like Nivo/Ipi or CTLA-4-based regimen in the second line. There's really no level 1 evidence to date, and we're awaiting the IMbrave 251 trial as the first large phase 3 trial to inform on this subject. If patients received a first-line TKI, then it is very reasonable per NCCN and other guidelines to proceed with one of our first-line combination checkpoint inhibitor regimens available depending on your region and the patient factors that Peter already so nicely alluded to based on our existing first-line trial data. So without returning to this case, so this patient had received a frontline immunotherapy regimen, then progressed on treatment. So for discussion, I'll ask, maybe I'll start with Anthony. Let's say this patient received atezo-bev as first line. What would you use next in this fit patient who's still Child-Pugh A, has metastatic disease, he's not a candidate for local therapy?
Yeah, and I mean, again, the answer is difficult, as you alluded to. So in this case, I've gone one of two ways. Usually, my most common pathway has been to switch to a TKI, and then if the patient is still fit with preserved liver function, then revert back to an immunotherapy-containing regimen with a CTLA-4. But I don't think it's wrong at all to go from atezo-bev to a regimen containing CTLA-4 in second line either. I just find the TKIs harder to tolerate the longer you wait, so that's why I try to sneak it in a bit earlier.
Yeah, nothing to add really. I mean, in the end, it's sort of simple. You ask the question what was used in first line, and then you try to change to something different, which is available. Those are the issues worldwide, and that might in different countries not be the same options. There are lots of sketchy data telling you that basically everything, even IO after IO, may work for some patients. We drastically lack biomarkers. That's our problem, to predict any sort of response to a given therapy.
And I think, accounting also for the goals of therapy and the patient's quality of life and individual wishes may also influence that, right? So.
Yep, and I think also time interval, and there's all sorts of individual patient decision-making, but these are the options today, and we hope we have better trial data in a year or two to present next time. So with that, Anthony.
Okay. Well, Peter and Katie are tough acts to follow, so I'll do my best. And I have to say that my section is a bit more complicated, so you have to stay awake, because the data is a little bit harder to interpret and apply, in my opinion. So, case to set the stage, 45-year-old Asian woman with chronic Hep B, presented with abdominal pain and BCLC-B HCC, so intermediate stage liver-limited disease, preserved liver function, good performance status, but the disease is bilobar, multifocal, with the largest lesion being 6 centimeters, no vascular invasion. So keep this in mind as we visit the options. So first, my session is going to focus on moving systemic therapy into the intermediate stage. But before we talk about that, the launch trial, if you recall, was conducted mostly in China and really asked the question whether the addition of liver-directed therapy to systemic therapy improves outcomes in advanced stage HCC, not in intermediate stage. So these patients had, quite a higher tumor burden and could have had vascular invasion or extrahepatic metastases, but well-preserved liver function. And the randomization was to lenvatinib plus TACE or lenvatinib alone, which would be the standard at that time. Primary endpoint was overall survival. The trial really included a very broad range of patients, and there were not a lot of parameters around how TACE was used and how many. But nonetheless, with all these caveats, you see that the addition of TACE to lenvatinib in this population improved overall survival and progression-free survival and had a higher response rate. So numerically, the median OS with the combination was about 18 months, and the median PFS was close to 11 months. Now, there are some limitations to this, how this study was designed. I still question whether this really applies to every single patient, if their tumor burden is mostly outside of the liver or not, for example. And also, of course, lenvatinib is not currently the most commonly used first-line regimen. So, but proof of concept that sometimes achieving maximum liver control of disease in the liver may be valuable. So what is the rationale for combining liver-directed therapy and systemic therapy in earlier stages, specifically intermediate stage HCC? One is we have effective systemic therapy with level 1 evidence for improved survival, introducing effective treatment prior to possible liver decompensation. We know that patients with HCC are really most of them dealing with two diseases, is the cancer and the underlying liver dysfunction and cirrhosis, which may progress over time. So incorporating the most effective therapies earlier is critical. Intermediate stage HCC is a heterogeneous group of patients. You could have 1 or 2 lesions, you could have 10, they can have different sizes, different distribution. So in those patients with multifocal or bilobar disease, optimizing control needs maybe more than one modality potentially, we will see. And then potentially preventing progression can decrease the chance of developing portal vein thrombosis and extrahepatic spread, which are poor prognostic markers, and then potentially eventually increasing cures. Very complicated slide for a simple message. Choosing the right patients for TACE is critical when we use TACE alone. So this is one of the prognostic models that was developed based on over 1,600 patients, where the ideal patient for TACE is a patient with preserved liver function, maybe Child-Pugh A or B7, good performance status, no vascular invasion, no extrahepatic mets, no prior tumor rupture, and no decompensation of liver disease. But besides that, there is clear data that the more lesions you have and the larger the lesions are, the lower is the response to TACE and the shorter is the overall survival. So if you look at the table below, with less than or equal to 6 lesions, the median OS with TACE was 49 months. And then if you have greater than 12, you're down to 16 months. And again, this is a model, but in reality, it's difficult to TACE patients with multiple lesions in the liver because you are chasing your tail. You treat one area to wait to treat another, and the liver function may deteriorate. So this is important to set the stage. What is limiting TACE usage in this space? Another thing to keep in mind, which is along the same lines, if you look at the light blue types of situations, these are the patients based on the data to date who may benefit the most from liver-directed therapy, specifically TACE in this case. But if you get larger lesions in the dark blue especially lesions over 6 centimeters or more multifocal disease, especially greater than 7 lesions, the response to taste is definitely more limited. So it's a heterogeneous disease, and multidisciplinary discussion is very important in deciding how to approach these patients. Now let's look at the data in intermediate stage HCC where we combine systemic plus liver-directed therapy. And when they say systemic, we're talking about IO-based therapy. So EMERALD-1 is this 3-arm study that you see here. Patients with preserved liver function, liver-limited disease. These were not amenable to curative approaches, no extrahepatic metastases. This study allowed small branch portal vein invasion, what's called VP1 and VP2, and no prior systemic therapy. In all 3 arms, patients got TACE, and in arms A and B, they got TACE with durvalumab. In arm C, they got TACE with placebo, the placebo for durvalumab. They were allowed up to 4 TACEs. After that, in arm A, patients went on to receive durvalumab with Bev placebo. In arm B, they went on to get durva plus Bev. And in arm C, they continued on just placebo for both. The primary endpoint was progression-free survival, with the focusing of the comparison, primary comparison was arm B to C. So durva TACE followed by durva Bev versus TACE alone, basically. And this was a positive trial when we look at the primary endpoint of progression-free survival. So the TACE durva followed by durva Bev led to a median PFS of 15 months compared to 8.2 months with TACE alone. A hazard ratio of 0.77 was statistically significant. Of course, for the other arm, which we didn't highlight, where patients got TACE durva followed by durva alone, there was actually no difference in PFS compared to TACE alone. So now you may say, well, this is a heterogeneous group of patients. Was there a specific subgroup with a certain tumor burden that benefited the most? What this slide suggests that based on the number of lesions, less than or equal to 6, and this was pre-planned, 6 to 12 or greater than 12, that there was really no difference. All groups seem to benefit from this approach as far as PFS and time to progression. So now, to follow up on this, there are other ongoing trials. EMERALD-3 is asking a different question with a different regimen. So rather than a Bev-containing regimen, it's asking whether TACE plus durva-tremi and lenvatinib or TACE plus durva-tremi do better than TACE alone. And then in the United States, as you know, the usage of TACE has decreased significantly at most centers, and Y90 transarterial radioembolization has gained more significant traction. So based on this, there are 2 trials, even though these are single-arm trials, trying to answer the question whether we get similar safety and activity to what we see with the TACE combinations. So EMERALD Y90 is durva-bev after Y90 tear, and Rowan durva-tremi after Y90 tear. Endpoints of PFS and response rate here. These are phase 2 studies. Okay, there's another phase 3 trial in this intermediate space called the LEAP-012 trial, looking at another combination, which is a combination of lenvatinib with pembrolizumab. So pembro is an IO with a TKI versus basically TACE alone. And similar patient population, except this trial did not allow VP1 or VP2. The other thing about this trial is that the therapy, the combination started immediately. So patients started with the systemic plus TACE concurrently versus EMERALD-1. And then in this trial, all the lesions must have been able to be treated with TACE with 1 or 2 sessions, and up to 4 TACEs were allowed. The primary endpoints here were co-primary endpoints of PFS and OS. And again, we see a similar improvement with this approach, with a superior PFS with the combination of TACE, Lenva, Pembro of 14.6 months. So very similar to what we saw with Emerald-1 with Durva-Bev, and 10 months with the control arm of TACE with placebo. Now, on initial presentation, the immature OS, there was potentially a slight trend for an improved OS with the combination, but we heard through press release that on further follow-up, the OS endpoint appeared to be negative, and we are waiting to see the details of that data. Now, this slide is busy, but basically a simple message. There is a price to pay for the combination of liver-directed therapy plus systemic versus TACE alone. You have slightly more grade 3 and 4 events. I mean, they're manageable events, and patients are able to stay on treatment, but there is a price to pay. Numerically, the grade 3 and 4 events are higher with the Lenva-Pembro-TACE combination because of the nature of TKIs as well. But there were no new treatment adverse events. These were expected and well known for these agents. In both studies, there was a certain level of discontinuation of treatment as well with the combinations that was higher than TACE alone. So there's more data building in this space. So one of the newer trials, this is mostly from Japan with Talent Taste, which again took a similar patient population. The sum of tumor maximum diameter plus tumor number must have been 6 or greater, so a higher tumor burden, no prior systemic therapy, and the patients were randomized to get on-demand TACE versus on-demand TACE concurrently with atezo-bev. Primary endpoints here was what's called TACE PFS, and I'm going to show you what that is, and the other primary endpoint is overall survival. So how was this TACE PFS endpoint defined? It's time from randomization to untreatable progression or TACE failure, refractoriness, or death. So how was untreatable progression defined? Is intrahepatic lesion progression, TACE failure or refractoriness, and this is a definition used in Asia very well, where if you need more than 2 TACEs to achieve more than 50% necrosis, that's a failure of TACE or refractoriness of TACE. Appearance of extrahepatic spread, deterioration of vascular invasion, and deterioration of liver function all were considered progression. And then death from any cause. So the endpoint is a bit unusual, doesn't certainly have the same level of validation as PFS, but it's a practical endpoint, certainly. And in this study, the concurrent approach of TACE with atezo-bev did lead to an improvement in TACE PFS with a median of 11 versus 7 months, and with regular PFS that's assessed with RECIST 1.1, 10 versus 6 months. The OS here is again immature, so we will see how this develops over time. There are other ongoing trials of immunotherapy with liver-directed treatment, and there's different variations that I'm not going to spend a lot of time on today. And there is a single-arm trial, phase 2 type study, with a triplet combination, Nivo, Epi, Cabo plus TACE, that's being presented at this meeting. So here's my summary on this space. Intermediate stage HCC is heterogeneous and complex, and it's a difficult area to generate data. Concurrent liver-directed therapy plus systemic, we have 2 positive trials for PFS, Emerald-1 and LEAP-012. The OS is negative for LEAP. It's pending for Emerald-1. The consistent results is showing statistically and clinically meaningful benefit in PFS and response rate, and feasibility is established. Where is the challenge? This is a heterogeneous group of patients, and some of these patients do very well with liver-directed therapy alone. So we have to think about the toxicity, and including the financial toxicity of doing a combinatorial approach in everybody. So we need a more nuanced risk-benefit assessment within this population. What is the ideal regimen? Is it containing VEGF or not? We need longer follow-up, certainly, to get more OS data. But what is the ideal approach? With EMERALD-1, the benefit was in the arm where the patients got TACE Durva followed by Durva-Bev. So is it really bringing the effective systemic therapy earlier that makes a difference? Is it the sequential approach, or is it a concurrent approach? With LEAP, it was more of a concurrent approach from the get-go. What about systemic therapy alone? I'm going to show you some data that Dr. Ghali just presented. Also, where does Y90 fit in this space? So, in my opinion, we don't have regulatory approval for any of these regimens. But there is a subset of patients for whom this combination approach may be an important approach. In my personal opinion, and I highlighted personal, patients with preserved liver function and performance status, higher tumor burden, who may be able to convert to a curative therapy may benefit from this combinatorial approach with the higher response rate and higher PFS. And we are certainly looking for the evolving data for systemic therapy alone in intermediate stage HCC. So let's look at a teaser in that space. This is data, older data from Japan, where Dr. Kudo and his team had already shown, I don't want to spend too much time on this because I'm running out of time, that in patients with higher tumor burden with liver-limited disease, through propensity score matching, that lenvatinib outperformed TACE in this patient population. So Dr. Ghali just presented at ESMO the interim analysis, first interim analysis from phase 3 ABC HCC study, which compared atezo-bev to TACE in intermediate stage HCC. This trial has a very practical approach. It's a larger study with 320 patients. In the control arm, patients got TACE until as long as they were TACEable versus atezo-bev for up to 2 years. And you see stratifications and the follow-up assessments. Now, the endpoint in this study, it was time to failure of treatment strategy. So in the trial, the time to failure of treatment strategy meant that for the systemic therapy arm, patients must have had radiologic progression plus deterioration of liver function or increasing symptoms. In the TACE arm, patients must have had either radiologic progression or stability plus either worsening of performance status, worsening of symptoms, or worsening of liver function. So with that, now why was this endpoint selected? And Dr. Ghali can comment on this. It's a practical one. It's unfair to you. It's hard to compare liver-directed therapy to systemic. So choosing this endpoint was a practical way to kind of maybe establish a more fair field for both. So with that in mind, the atezo-bev arm had superior time to failure of treatment strategy with a median time of almost 16 months versus TACE at 9.5 months with a hazard ratio of 0.5. Now, this is the first interim analysis. We look forward to seeing more data and to seeing the survival-related endpoints as well. Okay, going back to our case, this is a patient, again, with BCLC-B disease, bilobar multifocal with a largest lesion measuring 6 centimeters, no vascular invasion. What treatment options would you be considering? So I'm going to turn to my colleagues here and maybe just chat briefly about this. Is this a patient you would do TACE alone in at this point, Katie?
Is she someone who might be downstageable to transplant with a good response, hypothetically?
Let's assume so, yes.
I think your point earlier about what's the end game here does play a role in this question, because if it's a young, healthy patient like this, where if we do achieve a good response and control and a waiting list stability to be eligible for either resection or transplant, I think I would go with the EMERALD-1 approach based on PFS and disease control. If it's somebody who is never a candidate for a curative therapy and we're doing sequential therapy for the rest of their life, I probably would not. based on the toxicity and the medicalization of a patient who otherwise might do well with serial TACEs.
Yeah. I think, Peter, would you agree with that, or how would you approach it?
Yeah, I'd like to add that it's very relevant to have the full spectrum of information, and that in respect to traceability includes the feeding artery, how defined the tumor nodules are. Are they rather diffuse with respect to their border, or are they well defined? So they are very nice patients for TACE, and that will remain also in the future, but others may be not, and that is all the information we need.
Yeah. So we have different scenarios here, like if the patient had VP2 or VP3 tumor invasion or a high AFP, does that sway you one way or another? Do you change your approach with one of these?
I think I also would consider systemic therapy alone in someone who had VP3 and a super high AFP. Again, I don't think we should discount the fact that the toxicity is much higher in combination. If we look at, say, the LiPo-12 trial, grade 3 or higher treatment-related adverse events was 71% versus for pembrolizumab TACE versus only 30% for TACE alone. And again, this is a lifelong plan for these patients, so I think we can't discount the toxicity.
And no question that in reality, for these higher risk patients, some of us definitely start with systemic therapy. And if you achieve a great response, then bringing in liver-directed therapy. So this is more the multidisciplinary, real-life approach that's not really been evaluated in trials at this point. Back to you, Katie.
All right. And I have to say that was a fantastic overview of something that is incredibly complicated. So thank you, Anthony. And Anthony had the privilege of giving the most complicated set of data tonight. I have, again, the privilege of presenting the most data-free area. So I guess that's a luxury, but it's also a little tricky too. So I'll try to be clear where we do and don't have data here. So here's another case to set the stage. This is a 54-year-old man with MASLD cirrhosis who presented with a large unifocal HCC. You can see arterial enhancement. It's confirmed that it was washed out and was LIRADS 5 on portal venous phase. 7.5 centimeter lesion, no vascular invasion or metastases, good liver function, and it turns out was a great candidate for resection, so underwent resection. So what are our options in the adjuvant setting? So when we look at HCC, as always, you've heard over the years, this is a story of heterogeneity where not all tumors are the same. Some tumors are exquisitely immune responsive and respond very well to immunotherapy. Others are very cold tumor microenvironments. We don't yet have biomarkers to assign patients to one category or the next, but in really intricate immune profiling studies, we can see, this is from Dr. Jove, Daniela Sia. So in immune profiling studies, we can see that these tumors are not all the same. Some have very rich immune environments, but the majority are actually rather cold. And part of the reason that the HCC develops is thought to be a lack of immune surveillance in the liver. And it leads us to posit that some of these patients may actually benefit in the adjuvant or neoadjuvant perioperative setting from immunotherapy. And so how can we use our current immunotherapies in the perioperative setting? So when we look at which patients are actually candidates for hepatic resection, this is just a reminder of what we're dealing with or what our surgical colleagues are dealing with and making decisions based upon. The general principle is that surgical guidelines generally recommend surgery for patients with single nodules. There is no maximum size. The decision-making is really dependent upon, does removal of that tumor, however big it may be, leave leftover liver that's enough to do the job of the liver? Does it have an adequate liver remnant if you take out that tumor, however big it is? Patients, therefore, also have to have good liver function without significant portal hypertension. Signs of significant portal hypertension include esophageal varices or EV, low platelet counts, or enlarged spleen. So those are red flags that a patient can't tolerate much of a surgery. And we see that with low portal hypertension or very good liver function, 5-year survivals can be similar to that with transplant, up to 70%. But if there's significant, clinically significant portal hypertension, such as elevated bilirubin, the survival is much lower. And generally, we need to have the more cirrhosis or the worse the underlying fibrosis, the more liver you need to leave behind, which makes sense in order to sustain life. And then the problem is why we start talking about immunotherapy in these patients is surgery is not a cure in most patients. The recurrence can be up to 70% at 5 years, depending on risk factors. And so here's just a quick snapshot. A host of different factors correlate with a high risk of recurrence after surgery, including multifocality. So if there's more than one tumor or satellite nodules, higher risk of recurrence. If the tumor is poorly differentiated, higher risk of recurrence. If the tumor has vascular invasion, that's a very strong risk factor for recurrence. If the tumor has a high baseline or postoperative AFP, that's probably the strongest risk for recurrence, at least in older data sets. And now we actually have data that postoperative ctDNA positivity or methylation patterns are significantly associated with recurrence. So we can subgroup our surgical post-op patients into high risk, intermediate risk, low risk. There's a ton of nomograms out there to do so. The big picture is that multifocality, high AFP, high circulating tumor DNA, and these other features, vascular invasion included, high risk greater, approaching 70% or greater at 5 years, and the super low risk with none of those features are more likely to be cured. So question is, how can we change that fate for these patients? And this is a summary of where things stand with adjuvant therapy. On the last slide, there was a little snapshot of the STORM trial. Those of you may recall a long time ago, sorafenib was studied in the adjuvant setting. Unfortunately, did not change the bar and did not move the bar and did not show an improvement in postoperative survival. More recently, we have 2 studies, and I'll show you more details about the IMbrave 050 next. But this is the high-level summary slide in which we have 2 trials that have reported, 3 ongoing, that take patients with some high-risk features such as multifocality, high AFP, vascular invasion, like I already went into, who go through surgery and then give them either adjuvant atezo-bev in the case of IMbrave 050, adjuvant pembro in the case of Keynote 937, and examine whether this can help lower the risk of recurrence. And so in these first 2 trials, unfortunately, they have both reported out negative results in terms of improvement of recurrence-free survival. And in the case of Keynote 937, also overall survival. 3 ongoing trials are to be watched for on the horizon, including Checkmate 90X with nivolumab versus placebo, Emerald 2 with durvalumab with or without Bev versus placebo, and then in predominantly Asia, different PD-L1 inhibitor toripalimab versus placebo. So let's delve a little bit into the most mature data that we have so far, IMbrave 050. This trial was launched after IMbrave 150 in the advanced disease setting, showed, as Peter so nicely demonstrated, the significant survival improvement of atezo-bev in advanced disease, and took patients who had at least one high-risk feature for recurrence after surgery or ablation. About 90% of patients were surgical patients, about 10% were ablation patients. All of them had to have at least one high-risk feature, such as large tumor size, macrovessel invasion, poorly differentiated tumor, or multifocality. Those patients were randomized to get a year of atezo-bev in the treatment arm or active surveillance in the control arm. And crossover was permitted if patients recurred in the active surveillance arm. So at the initial interim analysis, we see that these curves, this is recurrence-free survival. We can see that on atezo-bev and soon after atezo-bev, we see a nice separation, and the initial interim analysis looked positive of the study where atezo-bev treatment arm showed an improvement in recurrence-free survival compared to active surveillance. Unfortunately, though, with prolonged follow-up and a mature final analysis, that recurrence-free survival was lost, and there was it ended up being a negative study on the final analysis. Thus, the unfortunate take-home is that though there may have been a delay in recurrence-free survival, overall there was no improvement in recurrence-free survival. Thus, adjuvant atezo-bev is not a recommended regimen. There was also higher toxicity, as expected, with the combination compared to active surveillance. This is the updated overall survival results. To accompany those RFS recurrence-free survival results, active surveillance in the orange shows really that there's no significant improvement in overall survival at multiple looks, including the interim and follow-up time points for the blue curve of atezo-bev. That was sustained with multiple looks and more mature data, unfortunately. So again, this is a negative study without improvement in either RFS or OS with prolonged follow-up. So what about the trials on the horizon? These are two U.S. Or international trials to keep an eye on, as mentioned earlier, adjuvant nivolumab, and in the Checkmate 90DX trial, and then Emerald-2 looking at adjuvant durva-bev or durva placebo or placebo. So we'll get a little bit more data, though, of course, with I mentioned earlier, the pembrolizumab adjuvant trial recently reported negative results. So it's hard to know if we'll be able to expect much from these very similar regimens to Embrave 050 in the case of durva-bev or Nivo in the case of the Pembro study. Now, shifting gears a little, what about a different strategy, looking at immunotherapy before surgery in the perioperative or preoperative setting? And this is where we get to the data poor part of my second talk here. So again, the disclaimer is that I'm about to show some very small studies that have intriguing signal, but are not yet ready for practice changing. So this first study is out of a group at MD Anderson led by Ahmed Kassab. And as you can see in this somewhat complicated schema at the top, what Ahmed and team did was look at the combination of Nivo-Ipi and Nivo in the perioperative setting in patients that were resectable or borderline resectable. And then patients underwent surgery. Their tumors were evaluated, and then they received additional Nivo-Ipi thereafter. And this is a small study, but what we can see, the key points of interest, again, hypothesis-generating type findings here, are that pathologic responses were seen in about 30% of patients on the operative specimens, including a complete response in 5 patients, and increased necrosis in a 6th patient that was very substantial. And we can see that this was associated in the interesting translational results with an growth of T-cell infiltration, CD8 positive T-cells in particular. Again, sort of a proof of principle that this, in the setting of an in situ tumor before surgery, giving immunotherapy can prompt T-cell infiltration, achieve a response in a subset of patients. And encouragingly, with this sort of short duration of neoadjuvant or preoperative therapy, in this small, carefully selected cohort, patients were able to proceed with surgery without toxicity complications. So again, an intriguing signal-finding study, but a very small cohort. A similar result comes from the group at Johns Hopkins, Ho et al., that looked at neoadjuvant cabozantinib plus nivolumab in the preoperative setting, so before surgery in patients that were borderline surgical candidates. And this is, again, a very small study and intended to be hypothesis generating, not practice changing. But I think they treated about 15 patients. 12 of the patients ended up being able to have surgery. And they saw major pathologic responses to the Cabo-Nivo regimen in 4 of those. So leading to a pathologic major or complete response in 42%. And this was correlated with radiographic tumor regression. So again, an intriguing signal of the principle that perioperative treatment could be beneficial in a subset of patients. A larger retrospective analysis or actually a mixed analysis of some prospective and some observational data was conducted by Alessio et al. And looked at about 111 patients, some in a subset shown here in Asia from a cooperative group, some in North America, and also a European cohort, and looked at patients who underwent IO therapies across a spectrum of IO and then went on to receive surgery. And what they saw is that pathologic response did correlate with relapse-free survival. So the subset of patients that ended up having a pathologic response, in this case, we see there was about 33 out of the 100 patients, so around a third of the patients, had a prolonged relapse-free survival, suggesting that this biomarker does correlate with the clinical outcome of interest, which is relapse-free survival. So again, an intriguing signal. Another study called NeoLeap HCC also shows the potential for pathologic responses with a different neoadjuvant or preoperative regimen, in this case, Pembro and lenvatinib. We can see a rather encouraging waterfall where patients achieve tumor regression radiographically, and these little red asterisks correlate with pathologic responses on operative specimen. So again, reinforcing the signal that there's a benefit, a anti-tumor response occurring. The caveat here, though, is that there was still relapses, and 12 of the 37 patients in this small study ended up having recurrence within just about a year of follow-up, 11.9 months, which is a bit discouraging at such an early time point, and reminds us that while these numbers are nice, to Anthony's point earlier, these treatments do come at a price, and we really need to wait for long-term follow-up to know if prolonged disease-free survival and overall survival will accompany these nice short-term outcomes, such as major pathologic response or the short-term recurrence-free survival. Again, hearkening back to that, the level 1 evidence I showed from IMbrave 050, where the initial look at recurrence-free survival was positive, but with longer follow-up, it eroded. So these data that I just showed, these 3 trials, the 4 trials in the perioperative setting, again, are intriguing, but very early, and they absolutely need longer follow-up for both RFS and OS. So I want to close with one prospective trial that is shown here that was presented at ESMO just in late 2025, CARE-009, of the combination of perioperative camrelizumab and rivoceranib, a regimen that has shown activity and is approved in the advanced disease setting in China, not approved in the US. In this study, patients were randomized, surgical candidates were randomized to receive either camrelizumab plus rivoceranib perioperatively and postoperatively, so in a preoperative and postoperative setting, I should say, with surgery in between, or a surgery alone group followed by active surveillance. Primary endpoint was event-free survival. The key results presented at ESMO are that there was, at the follow-up time point, I think there was, we double-check, 21 months or so. Yeah, 21 months of follow-up. We see that the red curve here for the combination arm did show a prolonged event-free survival compared to the control arm without perioperative therapy. And that major pathologic responses were seen as defined by, I think, 50% reduction in viable tumor cells in 35% of the patients. So there was activity on the pathologic specimens and a prolongation in event-free survival at this initial time point. But again, there is a price to pay. There was a high rate of treatment-related adverse events. 38% had grade 3 or higher, and only 19% of patients completed the postoperative course of therapy, presumably due to toxicity. And so this is, although not clearly stated exactly why. And so again, this must be taken in totality. And the toxicity is shown here, where we can call out treatment-related adverse events in 91%, grade 3 or higher 38%, and discontinuation rate in the perioperative setting of 15%. But again, only 19% completed the adjuvant side of things. And so concern for attrition due to toxicity, and again, take-home messages that we need longer-term follow-up to incorporate this into standard practice. But actually, before I close, I'll show a couple other trials ongoing to be alert for. In the perioperative setting, we have studies of pembrolizumab plus lenvatinib, and then its quadruple combination shown here, and then in a neoadjuvant atezo-bev study. All of these are small studies, but will give us more translational data and hopefully reinforce or help us understand the signal we're seeing so far. So returning to this specific case, this patient who underwent resection, I'll pause and ask my colleagues, I guess starting with Peter, based on what we know today about IMbrave 050 and 937 with adjuvant pembrolizumab, would you use adjuvant therapy in this patient?
Currently, there's no database. Very simple.
I agree as well.
And the unmet medical need is extreme, yeah, and the recurrence rate extremely high, but we have no evidence to support that.
I agree. And again, we can call out that I think we all would agree that a clinical trial would be optimal if it were available. So here's my take home on the perioperative setting. There's no current role for adjuvant immunotherapy post-resection or ablation based on IMbrave 050 and the pembrolizumab Keynote 937 studies. Small retrospective and prospective studies do show that major pathologic responses are possible with preoperative immunotherapy-based regimens and can be associated with prolonged recurrence-free survival. Although there's a lot of work to be done, we don't have a standardized definition for major pathologic response or standardized criteria for resectability for that matter. And what we really need are additional prospective studies and prolonged follow-up of the existing studies such as CARE 009 to determine if the initial event-free survival or RFS benefit or major pathologic response, in fact, are surrogates for longer-term EFS, RFS, and most importantly, overall survival. Are we helping our patients live longer and better with the strategy? We don't know yet. So with that, I think this is our final slide as a team. Peter, would you like to do the honors or shall I? Okay. So I think we're all excited that HCC is still a very rapidly evolving space with a lot happening with the combination of checkpoint inhibitors as a backbone, but other novel strategies to build on checkpoint inhibitors, whether other checkpoint antibodies, antibody-drug conjugates, bispecifics, cellular therapies. We have to remember this is a heterogeneous patient population, both based on demographics, etiology, and risk factor, but also the immune profile of the tumors at hand may be quite different, and so we need to keep looking for biomarkers, as Peter alluded to. Sequential therapies is very tricky, especially how multidisciplinary HCC is. As Anthony alluded to, we need to work with multidisciplinary teams, our tumor boards, and our IR colleagues, as well as surgical colleagues, to integrate our increasing armamentarium of treatment options, particularly in the systemic therapy space, to bring them earlier. And right now, there's still a lot of studies ongoing, particularly in the intermediate, adjuvant, and perioperative space that will hopefully be something we can talk about next year at this very meeting. And with that, thank you.
Thank you very much, Katie and Anthony. I believe we have 2-3 more minutes. Is that okay?
It looks like we have some questions from that.
Yeah, because we have some questions and we are very happy that our audience got involved. Let me get started here. In what kind of patient would you want to use lenvatinib or sorafenib instead of IO in frontline?
I think patients who have an absolute contraindication to immunotherapy, including patients with transplant who have a very high risk of rejection post-liver transplant or other solid tumor transplant or allo transplant for bone marrow. Also, patients with very high risk autoimmune disease, active Crohn's colitis, other active autoimmune disease can have a high risk of flare, particularly colitis flares, and really require careful risk-benefit discussion. And if a patient has maybe a low burden of HCC, that's a patient I would favor a TKI in first line.
But in the end, the group of patients not in the end tolerating IO is relatively small. And we take the risk, of course, in an informed patient. We have an increasing number of younger patients. Are there differences in approach versus older patients?
I mean, not at this point. The rise in various solid tumors in younger patients is intriguing. That includes HCC. I think we'll have to understand whether the biology in younger patients is different, but at this point we do not know. I think the only caveat I would say, potentially, if younger patients have HCC, do they have more preserved liver function, and will they be more amenable to aggressive approaches, right? Like combinatorial therapies, etc. We don't know. I mean, this is an area that we're going to continue to learn.
I think an important area is conversion therapy. Can we switch from a palliative situation to a curative intent? Transplantation, resection. And we can in individual patients. So, I mean, with the younger patients, I think we have a tendency to go all in and be a bit more aggressive, as it's better tolerated and maybe gain something in the end. But this is not evidence proven,
I would add, though, for the older patients too, even if we're just dealing with an advanced disease metastatic patient, now that we have multiple advanced disease regimens, I do think toxicity and comorbidity profile needs to play a role in our treatment decisions. So somebody who has significant arteriovascular disease, stroke risk, I might not pick a anti-angiogenic regimen out the gate. Conversely, someone with autoimmune disease, I might be less likely to do a CTLA-4 combination out the gate. So I think now that we have choices, like in breast cancer and other tumor types, like someone with neuropathy, we're not going to use FOLFOX as our first choice. we have those choices now in HCC.
And talking about side effects, is the development of immune-mediated side effects in any way related to outcome?
So, I mean, this is an area that's evolving, and it's kind of similar to other tumor types. Few things that I recall from more recent data, let's say with Nivo-Epi, there's certainly data to suggest that if a patient develops an immune-mediated event, there is no long-term detriment as far as outcome, even if you discontinued the therapy because of an immune-mediated event. There is some suggestion also that patients who develop immune-mediated events may have better outcomes, and that's a story that's reproducible across some other tumor types. So I think it's important to watch for these events and treat them, but not necessarily be afraid that they lead to a negative outcome. The other good news is that most of these events occur early in the therapy, usually most of them within the first 3 months, especially the hepatic immune-mediated events.
We did a subgroup analysis in CheckMate 90W, and it very clearly demonstrates a couple of things. First of all, those patients developing immune-mediated adverse events have a better outcome in general. Those who get treated with high-dose steroids do better. And even those who discontinued therapy did better than the rest. So in the end, it's hampering, it's affecting quality of life, but the anti-tumor response at the same time is better. We have many more questions. I'm afraid we are running out of time, and everybody wants to get some rest. So at that point, I'd just like to thank Anthony and Katie for excellent overviews. I think we really covered the topic in an appropriate way. It was very comprehensive. You and all those participating virtually for your interest and your questions, please take my excuse that we are not able to discuss them all. That's because of our poor control of time. But nevertheless, have a good evening and thank you for your interest.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, Blue Faery, the Adrienne Wilson Liver Cancer Association. This activity is supported through independent educational grants from AstraZeneca, Bristol Myers Squibb, ASI Incorporated, and Merck & Company Incorporated, Rahway, New Jersey, USA. To access all materials for this activity, visit peerview.com/FRD860.